Look, it's a great pleasure to have Jim Patrick speaking to us. I've known Jim for many years. He was scientist #1 at Cochlear and was very engaged and critical to the development of the cochlear implant, the multi-channel implant, under the tutelage of Graham Clark. In fact, they worked together closely for many years to develop what is now, of course, one of the world's leading, I would say the leading prosthetic implant, and the only sensory implant that is actually restoring people to full functional life. Jim has had an amazing career as an engineer in this bioengineering space. The big first slide here is the Cochlear building on the Macquarie campus, which is about 100 meters from where Jim and I are standing in the Australian Hearing Hub at Macquarie. And Jim has been instrumental globally, not only in driving the implant as a piece of technology, but in that patient engagement that actually engages patients in what a process that takes you from preclinical to surgery to rehabilitation to a life course engagement with a hearing device that engages you with everyone else. Jim is also very extolled with respect to his perspectives with as an AO and also as New South Wales Scientist of the Year last year. So it's a great pleasure to introduce you all to Jim, and you can hear a wonderful story of how technology engages with humans in the most intimate way. Jim, thank you very much. And apologies all for the slight technical hitch.
Yes, indeed. Thank you very much, David.
Up and down the days.
Okay. Golly. So, good afternoon, everybody. It's a great pleasure to be here and to share some thoughts about the history of Cochlear. We don't have very much time, even less than we had before, so I'm going to focus on the early years. I'll be able to respond to other questions later on. First of all, a little bit about myself. When I was 4, a little older than in this photo, my sister asked me to put my finger across the pins of a toaster while she plugged it in. Her parents had warned us not to do this, and she was curious to find out why not. And I still remember the feeling. And when I was 10, I had my first crystal set. I could hear radio stations 30 k's away, and no batteries were needed, just a piece of wire in the sky. Then I moved on when I was 17 to my first amateur radio. I got my license to use it, and I had a lot of early practical experience with this playing with electronics. Then moved to university, where I did a a science degree in physics, including 3 lectures on how nerves would respond to electrical stimulation. In my master's, my PhD was in progress when I heard about work being done by Graham Clark, and more about this shortly. Now, Graham was inspired by his father, who had a severe, profound hearing loss, and Graham often saw him in the pharmacy having a lot of trouble understanding what his customers were asking him for. And so he was really inspired to help people like him. And a relative of his recalls that from the age of 5, Graham said, "When I grow up, I really want to fix ears." He then qualified as an ENT surgeon and then moved into research, where he got a PhD studying sensory neural hearing loss. So a few slides on hearing and hearing loss. This is a cross-section of the ear, and you can see it, sound comes through the external ear canal, through the bones in the middle ear, and into the cochlea, where it causes fluid movements in the cochlea, which then causes nerve activity. And here's a slightly exaggerated illustration of these movements, showing how the sound movement, mechanical movement, ends up in nerve activity, which is then heard by the brain as sound. If we look at more detail at the cochlea, you can see that it includes 3 fluid-filled canals, spiral-shaped canals, and it's truly an amazing structure. Mechanical movements in these canals are transformed into neural activity in tens of thousands of nerves in the organ of Corti that's placed here. With the basal area being more sensitive to high frequencies, whereas the apex is more sensitive to low frequencies. So the organ of Corti is where the actual action happens, and movement of the tictorial membrane, as you see here, causes the hair cells to move, generating activity in the peripheral nerve fibers that then goes off to the brain. But if you have sensory neural hearing loss, you lose hair cells, lose nerve fibers and ganglion cells. And in cases of severe to profound hearing loss, it doesn't matter how loud the hearing aid might make the sound, they're going to be a very limited benefit. So here's a letter from an ENT surgeon in the late 1960s. And as it says, you have a complete bilateral sensory and neural hearing loss, and you'll end up making the most of a pretty bad lot. That was where the surgeons were. What about the researchers? Well, the opinions of leading researchers were not optimistic either, as you see here. Really, there's little you could do with severe profound sensory and neural hearing loss. But Graham continued to follow his dream. He thought, if I could put electrodes near the remaining nerves, then maybe one might be able to restore some form of hearing. And that's illustrated here, electrodes stimulating the nerves. So in his PhD, Graham conducted studies that showed stimulating different regions of the cochlear electrically did in fact generate responses in different parts of the auditory cortex. And that demonstrated the need for multiple intracochlear electrodes. And for low frequencies, you can see here, there's a good synchrony between the stimulation waveform and the brainstem potentials. So this led to the early version of Graham's vision of a cochlear implant. Outside the body, the sound is received by the microphone. It goes to the speech processor. Speech processor sends information through a transmitting coil to an implant, which then generates electric pulses in nerves in electrode array, which go off to the brain as sound. And from the very start, that was the concept. No wires through the skin, which is going to be a source of infection. Everything being done across the skin with an inductive coupling. Well, Graham he moved on from his PhD to be appointed Professor of Otolaryngology at the University of Melbourne in 1971. And you can see here, he's outside what later became the hospital being built behind in the first rooms he had as professor. And here's a picture of the multidisciplinary team, which Graham knew that he needed to have from the very beginning. And this is in 1976, and mostly PhD students with a very wide range of skills. And they mostly had a co-supervisor from another department. So that way he had access to very high level input from them. And here you can see me with a somewhat darker hair. And I've been introduced to Graham's work by David Dewhurst, who was the one who gave me the lecture on neural stimulation when I was studying in his department. And he was also a co-supervisor of Ian, who was one of Graham's students. Well, my job interview with Graham was interesting. And he had several questions that seemed to explore a need to think laterally. And it ended up with me asking Graham, do you think it'll work? And Graham saying, I don't know, but if it does, you might have a job. And that's how it all worked out. So looking at the University of Melbourne, 1971 to 78, and the research that was carried out there were acute animal studies, there were chronic animal studies, surgical studies, and engineering studies and development. And all of these were necessary preparation for the first in human feasibility study of the multi-channel cochlear implant. It was really essential work before you could put a device into a human research subject. Problem was there were no research funds. The research seemed to be outside the limits of what could be funded by normal research groups, NHMRC or ARC. But luckily, there were some very generous donors, including Sir Reginald Ansett, who was the owner of an airline, and of course, Channel O Melbourne, and the Channel O telethon, you can see here, a Christmas telethon, raised some very essential funds. And Graham was very creative also, and there were other techniques that could be used, one of which is shown here with the cartoon of Graham collecting, shaking a can outside the department store in Melbourne just before Christmas. And other team members also participated in that collection. That was very useful. Okay, some of the work that was going on as far as the electrode array design was concerned, then, well, it wasn't straightforward. One of the PhD students tried using the latest technology, depositing a thin film of platinum onto a polymer, but the platinum was very brittle and it cracked when the electrode was flexed. In another approach, the surgeons tried wrapping ends of lead wires around the bundle of leads. This ended up creating kind of a saw with the wrapped wires and a lot of damage to the cochlear structures, so that didn't work. The approach that finally did work was to use a thin silicone rubber tube with leads inside it, then coming out through the wall of the tube and then being welded to strips of platinum around the outside. And here you can see a sketch of this with the silicone tube, the wires inside, and the platinum foil electrodes wrapped around the outside. They were wrapped very tightly and welded, so they compressed the silicone tube so there are no sharp edges anywhere. Well, what about the cochlear implant? If you try to build one with valves or with transistors, you'd see it's going to be too big. But luckily, we were just in the right place and the right time as far as electronic technology was concerned, without using them. Looking at how much space we had, you can see that there's not a lot of room behind the ear. You can drill a bit of a hole in the bone, but it has to be quite a small volume processor. Well, again, looking at the technology, this is showing us Moore's law and how many transistors can be fitted into an integrated circuit as a function of time. And we were lucky, we were doing it here in the late 70s, trying to do it a few years earlier. We just could not possibly have made it work. And this just shows the picture of the digital decoder that was developed by Ian on the right-hand side for his PhD. And this is a picture of the gold box that I'm holding on the right. Inside we had a stack of 3 ceramic circuit boards with more than 40 chips and components, including a decoder for each of our 10 active electrodes. The gold box and construction was later described by a professional in the area as a work of art. And that group didn't actually go on to help us at all. So about our first volunteer, 1978. He was a man who had been deafened in a car accident. He had a wife and 3 teenage children. And despite very hard, he just found he could not lip read and they had to write him notes. Well, Rod was implanted, and following his surgery, he would come into the clinic 3 times a week, participating in a range of studies, and we could not have had a more committed research subject. The wall of one of our labs was almost covered in a rack of electronics, and our computer was state-of-the-art, with a total memory, as you see here, of 16 kilobytes, 1 million times smaller than the memory of your mobile phone. Well, when testing the loudness of short bursts of current pulses to a single electrode, we found that small changes in current, you can see quite small changes in current level, produced a very large increase in loudness compared to what would be happening if you're doing this acoustically. And so setting the appropriate minimum and maximum stimulation levels for each electrode was really important. These levels were different as you moved along the electrode array. And if we change the repetition rate, the stimulation rate for pulse bursts, you can see that the perceived pitch increases until it saturates at a pulse rate of about 300 pulses a second. Well, one of the projects we had was to make a cochlear model and to use that to control the stimuli where each channel, each electrode had independent outputs. We learned very quickly the interactions between overlapping stimulations from nearby electrodes would cause large variations in loudness, and this research was stopped. And instead we learned we had to use one electrode at a time using interleaved pulse trains. Apologies, I'm just going on a bit fast here, but there's a lot of work that was done. Before we got to Rod, our first subject. Now we tried several approaches, but we ended up with one where we tried to code features which were not visible on the face of the person that was talking. So this is acoustic information which you can't see, and so then stimulating that electrically. And that was our F0, F2 coding strategy. And you can see here this is being tested with sentences that Rod has never heard before.
In the end.
I hope that sound's coming through.
In the end.
In the
End.
end.
End. In the end. Put the coil back on. Put the coil back on. Can you hear me now? Can you hear me now? Is it loud enough? Good. In the end.
In the end.
There was so much material.
There was so much material
Wrapped around his head.
wrapped around his head.
He could hardly keep his balance.
He could hardly keep his balance.
He was then given a revolver.
He was then given a revolver. I mean, it's a wonderful demonstration of how the cochlear implant could help with lip reading. And with the implant, Rod hardly missed a word. He also did quite well with material he was familiar with when he was hearing it alone without any lip reading. So that was a very promising outcome. And that prompted Graham to write a letter to the office of the Prime Minister and see if he could get some support from there. And again, right time, right place. This is the response from the Prime Minister's office, telling Graham that they just established a fund to support Australian innovation for projects that were in the public interest. And so that was really a very important timing. And following the proof of concept and that letter, then the government, in fact, decided that the project could be funded as a project in the public interest. And in the first phase, they came up with $400,000 to implant 2 more subjects, pay for a market survey and a development cost plan to be done by the Nucleus Group after a competitive tender process. So a number of groups put in proposals and the government chose the Nucleus Electronics Group as the one to do that. Well, looking at the commercial situation at the time, Paul Traynor AO was the chairman of the Nucleus Group of companies, and he's known by many who were aware of activities back then, really as the father of Australia's medical device industry. And he was a key person in the participation of Nucleus in the commercial development of the cochlear implant in Australia. So we're looking now at 1981 and the cochlear origin. We have Graham Clark and the proof of concept with the team, and with patent protecting the crucial intellectual property. Paul Traynor and the Nucleus Group with relevant technology for building a clinical device and with global regulatory and marketing experience. And then we have the Australian government with the funding in the public interest project. The phase 2 funding was agreed after protracted negotiation. This would lead to the development of a clinical prototype and the implantation of 6 subjects in Australia in a pilot study. So the technology that the Nucleus Group had developed for pacemakers was really very applicable. And you see here underlined in red the hermetically sealed pacemaker encapsulated in titanium. It was a development from that we used directly for the cochlear implant. So this is the Tiger team put together by Paul. And I moved to Sydney from Melbourne, from Graham's group, as a technology transfer, while David Money was an integrated circuit designer coming from Telectronics, and Peter Crosby, also with an engineering background, moved in from the Royal North Shore Hospital. And our goal given to us by Paul was to develop a prototype cochlear implant system in 12 months. Well, that's a bit of a challenge for those who are working in this space today. Well, and it took us 13 months indeed to find some terrific colleagues and development partners, and to develop this clinical prototype in just 13 months. We used just a single integrated circuit, which you can see in here, which is effectively implanted then into 2 hermetic enclosures, one inside the other. We have 24 feed-throughs, many more feed-throughs than the pacemakers have, and it used an internal transformer to keep the external voltages to the coil to be very low. Damage as a result of electrolytic corrosion was a big issue for the one of the Melbourne devices. Well, this is the, okay, we've done that. This is the prototype processor worn on the belt. And the external coil, we just used one of these two, had a wire frame which held everything in place and held the coil over the implant. Here you can see the magnet holding the coil, which comes on a bit later in the game. So this is the system that was used as the device for the 6 subjects in Australia. And that was a successful study. They all had successful outcomes, and we learned that the system could work. The next step was to go to the US, and of course we needed to get venture capital to get started in the US, but unfortunately, where are we? Going to Price Waterhouse, we got the letter back saying that in their view, it was all too risky, and there's no way to get funding from institutional financiers. So where to go now? Good question. Luckily, the Australian government came to the party again and funded us with another $2.3 million for the US-based study, which gives it total funding equivalent to about $14 million in today's dollars. So this is the slightly modified processor now in a metal housing rather than the drain pipe that had been used for the early ones, but with the wire frame around the headset holding the coil over the implant. Well, in America, the cochlear implant was treated postlingually deaf adults, all with profound hearing loss. And there was a pretty skeptical ENT community because there'd been a lot of work done by different research groups with single channel devices coming out with quite exaggerated claims. And the ENT community really was pretty tired of it all. But we got some engagement. We had 2 US-based staff. Mike Hirschman came from Australia. Dana Becklenberg went back. She was an audiologist. And we had some secretarial support, so a very small team. But we did have some great advice from a statistician, which led us to the single subject repeated measures design. Now here, each subject was their own control, so you could compare performance without the implant running, so there was no need to have a placebo group. And the regulators were very helpful in reviewing the IDE. They discussed the design with them, and in fact, they ended up being very complimentary about the design. We had 5 centres with leading surgeons and audiologists. Well, kind of interesting experience. I had personal activity with a number of first in clinic subjects. I was the nominated troubleshooter travelling from Australia as necessary. And patient 1 in clinic X, the antenna array had coiled in the basal turn, so virtually he had a single electrode map. But when I talked to him, he asked me if I was British. So our F0 information was working very well. And the implant was revised and he got a good outcome. Second patient on the other side of the country had complained the device wasn't functioning. And it wasn't until I got there, but discovered when he said he couldn't hear, he just meant he couldn't understand. And he became a good performer as well. And I can't resist telling you about patient 1 in another clinic, not part of this study, but the device wasn't functioning. And I went there and lo and behold, the surgeon had implanted a silicon rubber model and the real device worked. So proper surgeon training is essential. Okay, on the clinical trials, we had 52 subjects with effectiveness data at 3 months and a total of 73 implanted, but not for that long. So we had safety data from them. And every subject stayed right through the study. And a comment from an FDA panel member, the best study I've seen. It was really a great meeting, the panel meeting. But we had FDA approval in 1985. Well, that was great. We got moving, but it was really important to communicate the outcomes, the benefit you could get from the implant, and just how well it could work. And so there were many publications and presentations at conferences by Graham, members of his team, and by people from Cochlear, and also visits to Melbourne and to Sydney by key opinion leaders from USA to start with, and also then from Europe, Japan and China. And that was really important to educate people and to show them some of the recipients and how well it could work. So having got things sorted through in the US, the next step was to go to Europe. And again, there was rather skeptical ENT community. And here they had a preference for extracochlear stimulation, mostly with single channels. And a number of different groups were trying this out. They were concerned about damage inside the cochlea from the electrode insertion. So our team was led by Mike, who went across from the US. And a key person in Europe was Ernst Lenhardt from Hanover. And he indeed had flown out to Sydney, to Melbourne, with his lead audiologist to talk to us. This is even before the FDA study had completed. He came across in 1983. But he was just crucial. The work he did in his own clinic and then teaching other CI surgeons, getting them started in more than 20 different clinics was just remarkable. We got regulatory approval using safety data, in fact, in Europe back then, and that was in 1985. Well, that was good. That was all adults. Now in children, work began in the mid-80s in Melbourne, but we moved that to the US clinical study, and we got approval in 1990 for children from 2 through to 17 years old. And that led to a global program to identify children born with severe to profound hearing loss using newborn screening programs and using a novel objective measures technology that we put into devices from 1989 that let audiologists actually detect hearing loss to detect stimulation using a cochlear implant without the need for responses from the children. You can test them while they're asleep, while they're unconscious, and actually know how to set the device up. It's had to be very important. So now, a few minutes on cochlear products over time. We started with our first magnetic connection to the external coil, the implant CI22 in 1985, and then increased the sophistication of the implant, just showing here to 2005. These early days, we go from the body-worn processors to a behind-the-ear processor. Getting rid of the cable and the body-worn processor was a really important thing. And then again, further improvements in signal processing to get better outcomes that you'll see shortly. But a really important thing was that the later processors are always made backward compatible with the early implants, so that someone who had an early implant could just keep on upgrading by changing the processors. Here's some illustration of the outcomes. And this is looking at speech perception of single syllable words in quiet, measured at 6 months after surgery, just showing the percent correct. Showing F0 F2 gave something. It was much more useful as an aid to lip reading, but a little bit, as I said before, of word understanding, more in sentences. And then as we increase the sophistication of the coding strategies, we add F1, that's the first formant frequency, then add go to multi-peak speak. I won't talk about exactly what these do, but then just with electrical stimulation alone, 2005, you can see we're improving further. And if you add some acoustic input, just from a very limited residual hearing, then in fact you get a significant improvement. And that went a long way into the future, but I don't really have time to talk about that now. But now we have people with single-sided deafness getting an implant in the deaf ear and doing very well with it as well. So just to look at the cochlear history and the work in Melbourne, this just shows the research relationship with Melbourne and all the things that came out of that over time. And there was a license agreement between the University of Melbourne, the Commonwealth and Cochlear, going back to the early grant funding, and that resulted in royalty payments until 2002. But you can see here all the work that was going on in collaboration with the team in Melbourne. It was really a wonderful benefit. Now we've got more than 100 collaborators around the world, but always Melbourne is special. So just a bit of an overview of the cochlear implant treatment and the different aspects of it. These remain as important today as they were on day one, but the basic science is crucial. Really a clear understanding of that and seeing how we can change things in basic science. We're now getting growth factors. There's all kinds of complicated stuff that has great potential to improve things. How we apply the research that we do to improve outcomes. Just looking at new technology. This has been tremendously important both for the implant and for the speech processor. And now we have a single, like a coil speech processor with a battery inside it and a magnet that just goes on over the implant. No need for the behind the ear processor anymore. It's all very exciting stuff. Design and manufacturing. I'll talk a bit more about failure analysis in a minute, but seeing how we can improve things all the time is really important, particularly as we're getting needs for more and more high volumes of products. And clinical practice, working with clinicians to improve awareness, to help with the surgery, the audiology and the habilitation. And just a minute, I'll get a light. And now with more and more recipients of our devices, the clinicians really need to have good access to them. I don't have time to talk about that now, but supporting the patients, whether it's from home using remote systems, or in fact engaging other clinicians in addition to the ones in the cochlear implant clinic, to be involved in supporting the patients is really important. So that's all going today. Yeah, okay, I think that will do for that one. So one very important study going back to 1996 actually was looking at the cost utility of the cochlear implant compared to other medical interventions. And you can see here that in adults, we're doing well. The threshold usually was 0.05 qualities per $1,000, but that's a very cost-effective intervention. And if we look at children, it's even more so. A lot of work is going on this now because the actual costs to society of deafness are very, very great. And to be able to help with an implant is a very, very cost-effective treatment. Looking again at children, this study going back 10 years from Melbourne again looked at how language develops in normal hearing children. You can see this green line or the blue line, and then the dark line showing language development for children who receive implants at different ages. And the benefit of implanting children while they're very young is clearly evident here. So that's indeed led to the newborn screening programs and the wonderfully effective treatments that young children have, so they end up going to a normal school with all the normal potential. From the day one, it's been very important to us that our implants indeed are reliable. Here, now, and always is where we've been up to. And this is just showing how for different models of implants, over time, we've managed to improve the reliability. We analyze every failure, find out why it happened, and then try and improve the next model. And you can just see here, the most recent model, the Profile Plus, has only been around for a few years, but it's the most reliable, and than ones that have been earlier. The 22M that we started with, sort of talking before, you can see we now have a number of failures there is significantly greater than the 24, than the 24R, and so on and so on. So we've certainly succeeded in improving the reliability of implants, although from the beginning they were the most reliable implants on the market. We're very proud of that. We had one case of a product recall. And so just looking very briefly at Cochlear today, coming down the right-hand side, we put a lot of money into R&D. Come back. We've got more than 60% market share. We've sold more than 650,000 implants, and the company is growing. We really value our collaborative research programs still, and we're now manufacturing at more sites. At the beginning, we were compelled to manufacture in Australia with an agreement with the government, but now, of course, we're manufacturing in China and in Asia as well. And that, I think, will do from me. And welcome David back, if he's about to come back to ask some questions. I've been too speedy.
It's Dale.
That's
an idea. What's the sort of costs involved with getting this done? The device, the procedure, that sort of the rehabilitation?
Look, maybe $30,000.
Okay.
Okay. Depending which country you're in. I mean, there are different costs in different countries, but in the developed countries of that order. Again, I'm not that close to this. I should have started with this saying I'm out of direct contact for the last 5 years, actually, since I retired in 2015. That's not really my special area, but that's the kind of money we're talking anyway.
And does Medicare cover the cost in Australia?
Yes, it does. Yeah.
Okay, thank you. I'm going to unmute everybody, I hope.
Yeah, absolutely. Yeah, I think children until the age of 26, then you have to satisfy certain requirements going above that. But yeah, it's good. Thank you, Aidan.
Thomas, are you?
Yes, I'm just trying to struggle with my mute button. Thanks so much. A fascinating presentation. I may have missed it. What about music?
Yes, music is a really interesting question. You have to work at it. We have a number of musicians who have implants who it can work, but it sounds very different, and yeah, it takes a lot of commitment to make it really successful. That's an area that we're very interested in.
The brain needs to do a lot of work.
Yeah.
Thanks.
I mean, you get I guess, as I showed in that very early slide, for frequencies up to 300 hertz or so, then that comes through quite well. But then all the harmonics, it's a bit of a different story. So, but the brain is amazing. The brain adapts, and so if you just keep trying, I think you can make it work.
I think anybody should be able to unmute themselves, and I could ask a question now if I've set the button correctly. Jim, did you see there's a question here? I was keen to hear what advice Jim has for recent engineering graduates working in cochlear or the medical device sector more broadly.
With respect to, I guess one of the things that, there are all different dimensions of this. One of the things that I found was extraordinary about things like this is that you talk to the people who've been treated with it, to the recipients, as we call them, and you can see the impact on them, on their lives, if they're kids, on the families. And that's just a wonderful thing to do, to be working in that space. So that's rewarding by itself. I'm not quite sure where to go with the question.
How do you get into this? Are there jobs in the field available?
Yeah, well, you've got to go again, look company by company by company, I guess is the thing. And Yeah, so the people advertise in different places. Yeah, I think if you find a company and then go to the HR group in the company and find out if there are spots there, would be the way to do it.
Jim, if I can just continue on, you seem to have in the early days done very well under both Conservative government and Labor government with the funding. Do you think there's still that sort of appetite to invest in this blue sky stuff today?
I do. I think I mean, there's this, I think, a perceived gap between academia and business still, and there are opportunities that are there, absolutely. If you've got an idea that you think it'll work, then there are organisations that can go and really help it to happen.
Was the University of Melbourne very proactive in pushing this?
Yeah, well, they were very supportive of, I mean, things like the CRC project that I showed you, which involves having companies actually making contributions to the program. So the company brings the technology, the university has a research interest. Together you can actually get funding from the government and you go ahead together in the research projects. So, and there are other sources like that. So that's certainly worth looking at.
Thank you. Any more questions from anybody? If not, well, I'd like to thank Jim and David, who organised today's topical lecture. Remember, these lectures are about trying to get people outside of their own small areas often and give you an exposure to things that can be done. And I think Jim's really shown today what can be done by a dedicated team who are obviously in it for the long haul. I think that was the message that I got. This wasn't a short time turnaround time for this, but that commitment and innovation was really rewarded. And I think, as Jim points out, that this makes an impact in people's lives. It's clearly life-changing, and for the amount of money that was suggested for $30,000, I would think the return on investment was just extraordinary.
You're absolutely right. I mean, over the life of the child, it's just massive. And it's not just the child that's impacted by it, as I said before, it's the whole family. I mean, it makes a huge difference.
So thanks, Jim. Tremendously inspirational talk.
Okay, thank you.
And thanks for all you've done in this area.
Okay, thanks again.
Thanks all.